Hello, everyone. Thank you for joining us today for our webinar entitled Alternative Payment Models, Prime Accountable Care, LLC. Prior to the beginning of today's presentation, I have a disclaimer to share with all of you. By participating in this Artarm Institute webinar, you are automatically agreeing to authorize recording of audio and visual content presented during this event and consent to subsequent use of the recording in the public domain by Artarm Institute. This recording may include questions and responses provided by you during the live event. This recording will be available after the conclusion of this event as part of Artarm Institute webinar archive and will remain indefinitely. If you do not wish to consent to the recording, please do not join this event. And if there's any questions, please contact Sylvia Romer at sylvia.romer@artarm.org. Artarm Institute webinars are intended solely to provide information to the public. The views and opinions expressed as part of these webinars do not necessarily state or reflect those of Artarm Institute. It is not intended, nor can it be relied upon, to create any rights enforceable by any party in litigation or to endorse any other organization or service. With respect to these webinars, neither Artarm Institute nor any of their employees make any warranty, express or implied, including the warranties of merchantability and fitness for a particular purpose, or assume any legal liability or responsibility for the accuracy, completeness, or usefulness of any information, services, products, or process disclosed, or represent that its use would not infringe privately owned rights. Today's presenter is Ms. Diane Blackburn. Diane is the Executive Director of Prime Accountable Care, LLC. My name is Keisha Ori, and today I'm today's monitor. During today's presentation, all participants' lines will be muted. If you have a question, please type in the question box in your GoToWebinar interface, and we will address your questions during the Q&A session. Due to the large number of attendees for today's webinar, we may not have time to answer all of your questions. If we do not address your questions during today's broadcast, you will receive an answer through email. Following today's presentation, a link to the recording and additional reference documents for Prime Accountable Care, LLC will be provided to you via email. Today, Diane will provide an overview of their organization to include the APM structure and performance record for quality and cost saving. She will also review time commitments, workload, onboarding, communication, the Population Health Management Platform, Collaborate, and their Population Health Management Program. Information provided will help you determine if you would benefit from further discussion with Prime Accountable Care, LLC. We are happy to facilitate any additional meetings if needed. Following the presentation, Diane Blackburn will take time to answer any questions you may have. However, please note, the information you will hear in the broadcast is current as of today and is only intended to be a general summary. I'm happy to introduce Ms. Diane Blackburn, who will begin today's presentation.
Thank you, Keisha, so much for the introduction. And yes, I'm Diane Blackburn, Executive Director with Prime Accountable Care. I've been with Prime since its inception, and I'm happy to join the webinar today as a speaker. So thank you, everyone who's participating. Next slide. So the agenda overall is just to look at ACOs, what CMS has as a quadruple aim, a little bit about Prime, how we work with practices, and have some engagement as far as how we're connecting and providing resources. An ACO overall, just so that everyone understands what it is, it started right around 2010 or so from CMS, born out of the Affordable Care Act. So it's only been around for about 8 years, and in its short time, the popularity is slowly growing. The number of ACOs across the country is growing, and CMS is trying to tighten and really put a focus on ACOs, on bringing the high quality, cost effective care to a select group of patients within Medicare, which is at this moment the fee-for-service or traditional Medicare patients. Yes, it's voluntary for physicians, but how CMS has things structured through ACOs, the support, the education, subject matter level experts, CMS is really pushing ACOs to really support physicians as they clinically and financially manage their patients. So next slide. So CMS's focus on when it really wanted to redo healthcare is they were looking originally at something called triple aim. And over the last year or so, CMS said, you know, there's a key component, a key stakeholder in this equation that we can't forget. So we're moving beyond triple aim and going beyond its initial premise of providing population health, improving, excuse me, patients' experience and care, reducing the total cost of care, and that fourth arm, if you will, or that fourth leg to this whole healthcare delivery system is really improving the work balance, the work-life balance of the healthcare providers. So Prime has always taken that the work-life balance and the function of providers extremely seriously, because when Prime was created, it really was created by providers for providers. So that's our focus. And next slide, please. And so as it was created, Prime was created to be a physician-owned endeavor. And what I mean by that is physicians, primary care who are aligning and joining with Prime, they actually receive an owner equity interest in the organization. So it's not just an ACO they're joining, it is an organization that they have an ownership stake in, which is extremely important in the ACOs that are available to physicians today, where very few offer the opportunity for a physician to have not just a seat at the table and be heard, but actually have an owner interest in the success of the organization. It's physician operated from the board level to committees and those mentors and physician champions. These are active participating physicians in ACO CMS program, and they are really building their ACO with physicians with whom they want to share risk. And I don't mean just risk contracts, but those colleagues that want to function at a high level of excellence and provide the highest level of clinical and financial expertise to their patients and then reap those benefits from their efforts. Prime was founded in 2015. We received our MSSP contract. It was a Track 1 contract with CMS on January 1, 2016. CMS has modified their Track 1 program, and as of July 1, that will be eliminated. And existing ACOs and even new ACOs are going into what now they're calling their GLIDE program. So Prime is continuing on with the CMS MSSP model, which will now be called Level B. Out of a 5-level program, we're entering in at Level B, which is still a one-sided risk model, no downsided risk. And then a year and a half from that July date, we'll enter into a two-sided risk model. Prime's comprised primarily of primary care physicians and mid-levels working with those primary care physicians, supported by select specialists within our geographic region. Today, of those traditional or fee-for-service Medicare patients that CMS has in their program, about 10,000 or so are assigned to Prime, and there's another 20,000 plus that are actually assignable, meaning that we still function and work with those patients, but at any time throughout a particular calendar year or program year for CMS, those assignable patients come into our platform, if you will, and we have direct responsibility to manage those. So actually, just over 30,000 lives that we're clinically and financially managing that we're responsible for. And Prime is really focused heavily in the Tri-County area, but we're expanding into Hastings. We have a foothold in Flint, and we have smatterings across Bay City, Saginaw, and Caro. And within the Prime family of providers, we actually have a large federally qualified health center and a few rural health clinics. So the expertise that Prime is bringing and the flexibility of provider we have in our fold really is from the independent physician to the FQHCs and RHCs. So our perspective and ability to work with various fashions of provider is very dynamic, very flexible, but we're always looking at the type of physician and really wanting to focus in on those physicians who want to remain that independent, entrepreneurial, and have their tin still remain with themselves, but join a very strong, forward-thinking, innovative ACO. That's what Prime represents and offers to the physician. So next slide. So that's a little bit about Prime, but how do we rank? And since we started in 2016, CMS publishes right from their own analysis on public reporting websites from cms.gov. Prime ranked, when you look at us just in Michigan, there's about 27 ACOs that's available to Michigan or to physicians in the state of Michigan. And of those 27, Prime ranked 5th out of 27 for generated savings. And why that's really important for physicians, especially those who are want to remain independent, that entrepreneurial spirit, and align with an ACO, is because when you look at the ACOs within the top 5, pretty much Prime is the only physician-owned and operated ACO within that top 5. And even when you look at the options, the 27 that are available to physicians in Michigan, we're only maybe about one of 3 ACOs that are strictly driven towards physician-owned, physician-operated ACOs. And for us, in our second year, to be awarded shared savings, of which we did, which was we had $13 million in generated savings. Again, as a physician-owned and operated ACO, to hang with the large hospital systems and the large corporations that are in multi-states, we're very strong. We're very focused on quality, evidence-based medicine, and really supporting and lifting up the independent physician so that they can be successful and everyone then has a win, the patient, the provider, as well as their ACO. We're going to turn to the next slide. So that's how Prime ranked based on the latest CMS 2017 public reporting stats. So then how do we rank nationally? So when we look at another key performance indicator, which is PMPM, per member per month, or per member per year savings loss, Prime actually ranked 18th out of 472 shared savings ACOs nationally. And when you compare us within the top 18, that stat actually puts us within the top 4% in the country. And I want to stress this again, Prime being a physician-owned and operated ACO, we're hanging among the large corporate national ACOs. we're hanging out there with large hospital systems. And the focus that we have on promoting and sustaining physicians to remain independent while having the support of a very well-structured, strong ACO is what Prime represents to the provider. So next slide. When we talk about Prime, we're very driven by success. We know that everything is interrelated, everything is a domino effect. So our success is the physician's success, and ultimately the patient is the one reaping the ultimate benefits. So we really start from the ground up, building a very strong foundation when a physician aligns with us. So we have a very formal onboarding process. We've actually tailored over the last few years what we call goals for success. It's practice level. It involves each key stakeholder of the practice. We outline very specific things that at a practice level they can be doing to engage with Prime as an ACO so that they can meet or exceed payer expectations. We're very focused on physician report card and that feedback. So we have designed a very specific mechanism to give providers a feedback, very timely and transparent and objective, those key performance indicators that a provider needs to be focused on. So it's not adding to their workload, it's enhancing practice management and elevating everyone to practice excellence in medicine. So we're building a very strong foundation, and we're doing it one practice at a time. And we understand that as Prime, we have some non-clinical people, such as myself, provider relations, that go out and meet with physicians and their staff, but that peer-to-peer mentoring is extremely important, and build that into Prime, and we think that's why we're also extremely successful, is the physicians that are active participants in the CMS ACO model that sit on boards and committees for Prime are very active, and each one of them take on a new physician that comes into Prime and existing physicians that are with us, and really have a peer-to-peer mentor relationship. So you'll hear from clinical as well as non-clinical support from Prime. You'll be engaged with subject matter experts that are aligned and associated with Prime, but never will a physician or their providers or staff feel that they're alone trying to navigate, an ACO model without, or a CMS, MSSP model without having that support by Prime, because we're here for the physician, being driven by physicians. So we're going to turn to the next slide, where again, being very driven by success, we knew that CMS releases on a monthly basis a large amount of data. And in that large amount of data, in order to make sense of it and make intelligent, timely, actionable decisions at the practice level or even at an ACO level to manage the overall health of the ACO for CMS contract, Prime needed to invest heavily in a very robust and dynamic platform that goes beyond an EMR, but works with a practice EMR to really provide true population health management. So Prime invests heavily on a monthly basis into a product called Collaborate. And this product is driven by patient claims. So it comes right from the payer. Everything is accurate and objective. We also incorporate physician EMR information into this platform, and we also take third-party information, perhaps either from a lab or other entities that we partner with, pull it all into one platform, which is Collaborate, and we're now giving additional pieces to the puzzle, to the provider, to make very intelligent, timely, actionable decisions. So they can look at their cost, patient claims data, print reports. Reports are already created for them for on-demand viewing, and there's other features that come right from the platform that once again help the ACO and the provider connect with patients and work with specialists with whom they have to entrust their patient care to. And again, it's all within one platform, easy to use, and it's provided by Prime to the physicians that align with us at no cost. That cost comes directly from Prime, so we bear that expense. Next slide. Obviously, really managing patients nowadays, it's not in silos any longer. One patient and you deal with what their chief complaint is for that day, but it's leveraging that opportunity when you're in front of a patient so that you can get the most out of that patient and really connect and build a strong relationship from provider to patient. So Prime has worked with one of our strategic preferred partners, and we've designed a very unique population health management program. We've created what we call Prime Plan of Action by mining all of that patient claims data received directly from the payer. We identify those high-risk patients that have the highest opportunity to bring about change. We create a plan of action, engaging the provider on what needs to happen. We get in front of a patient and work with the provider under their directive to be that eyes, ears, and voice of the provider with that patient and really engage true care coordination. So it's effective use of resources to improve efficiency and maximize outcomes. Once again, focusing on the mission vision of CMS and really looking at quadruple aim initiatives. Everything that Prime has built into its ACO is for the physician, meeting and exceeding CMS mission and vision so that we can be successful, and we're on the right track because we've had a phenomenal second year, and this fall we'll look at where we stand with CMS for 2018 outcomes. Next slide. Again, we can't do any of this without communication. And if it's not timely and transparent, then we failed in our part. So learning from lessons in 2016, how we need to really effectively work with physicians because everyone's so far so spread out across Michigan, is we've designed some communication tools. We have a Prime weekly bulletin that goes out to every one of the providers as well as our preferred partners, and it has timely information, anything that the provider or their staff needs to be aware of, so that communication is sent, and it's greatly appreciated by the physician network and Prime. We also do once a month what we call Prime Live, an educational webinar series where we invite subject matter experts to present to Prime physicians on various topics, anywhere from coding, high-risk coding, to population health management, and really helping further mentor and support the provider so that they can truly achieve that excellence in medicine. Board meetings actually occur on a monthly basis, and once again, they're comprised with 75 to 80% of the board is physicians who are active participants of Prime, and they actively manage practices. They're managing patients within the CMS MSSP ACO model. So again, it's physicians operating and driving Prime ACO. And those meetings occur monthly. Physicians that are with Prime are welcome to join it. Minutes are always available. And because physicians are spread out. We understand you've got a lot of work to do, and trying to keep that work-life balance always in the forefront of our minds. Yes, we do have physician meetings, but they only occur twice a year, so that you can, as a large group meeting, get to meet your fellow colleagues. We're not going to overtax or burden you with meeting after meeting, so that we can be respectful of a physician's professional and personal time while still making sure that we support the physician, guide, mentor physicians, provide all the resources and materials to physicians. You get to know one another at these meetings, but we're not encroaching too much on your time. We also engage one of the other key stakeholders in a physician's practice. So on the flip side of clinical, you've got operations. And so we created a very unique worker group called the Practice Administrator Forum. And it's for those office managers, practice administrators, even maybe the clinical care coordinator, if there's one at a physician practice. We hold these meetings quarterly. We're going to try and go now to every other month because of the request of the Practice Administrator Forum, where it's just those office managers coming together, again, either in person or via conference call, so that we can have discussions from the non-clinical side, the operations side, and how does that office manager help support the physician to be successful. And then office managers talking with each other, they get to learn from each other, and then that just makes everyone stronger as an ACO. And so this is not looking at as a competition among practices. This is looking at how do we strengthen every link in Prime ACO, in a link I'm looking at as a practice, so that each practice can function at the highest level possible to achieve excellence in medicine. We can't do it without the provider, and we can't do it without the operations person. So we have meetings specifically geared towards physicians as well as practice administrators. And then also, we take those CMS webinars and any kind of timely updates, and we do extend those invitations out to the practices. Most of the CMS webinars occur, unfortunately, during the day at inopportune times, but at least we make it available to the providers so that if someone can join in, they can hear something right directly from the payer, the provider, can then be educated and be on the same page with all of us. But none of that is mandatory from the CMS perspective. We just make it available to everyone so that we're sharing as much information as possible. Next slide. With connectivity and resources. So again, we can't be successful if Prime doesn't have the resources available to physicians so that they can clinically and financially be successful in managing their patients. And one of the first frontline resources that we have is a team of provider relations specialists that actually visit the provider offices on a 4 to 6 week schedule. So you will actually see provider relations coming to physician offices and giving that support not only to the providers but to the office manager and the staff throughout the entire practice. So again, we tailor that based on the physician need and request, and we do that so that we always keep in contact with someone to help make the provider the most successful that they can be. We also set up something called OneDrive folders. So it's a secured cloud folder that information is saved for each practice. Each practice has a secure link and invitation to view the information in that folder. So once again, in between an actual physical visit, you always have information that's provided to the practice in a remote way so that you can access it from wherever you are, and we can always stay in touch. Prime also created what we call a resource library. So as we come across information, whether we create it or it comes from a well-vetted resource or subject matter expert, we put it in a resource library that everyone that's aligned with Prime has access to, and they can use it at their leisure and to help strengthen resources at the practice level. Also, as we take on new information from other practices, we make it available to the entire Prime network so that everyone can take advantage of best practice protocols. And Prime also created tools and materials based on, again, CMS requirements and the subject matter experts. We make it available to you. We've also connected with MyHIN, which is the Michigan Health Information Network, and it's one of the larger health information exchanges, or HIEs, in Michigan. And we connected directly with them, and there's a direct feed into the Collaborate, our population health management platform that provides ADT data to the physician. So if any of the hospitals that are in Michigan, there's about 227 hospitals in Michigan, MyHIN works with 225 of those hospitals, so virtually almost every hospital in Michigan. When a patient has that admission, discharge, or transfer from an inpatient stay, that hospital is required to push it out to the HIE, and that HIE now dumps that information on a real-time basis into our Collaborate platform. So a physician provider never has to worry about if the information comes to their practice from a hospital. You know, if something glitches on a fax machine and you just don't get that information, not to worry, because we've gone above and beyond the need by providing this ADT data to the physicians through the population health management product that we provide to each physician at no cost. And then in addition, we pull in information into the IT platform from your EMR. So we do connect with physicians' EMR. We electronically extract data so that we can push it out to the payer. So to take some information and work off of your shoulders, we pull that full ACRS file, and an ACRS file is just all of your active patients. We push that out to the HIE so that you get that timely ADT data pushed right back to you for your use. And during quality metrics reporting season, back to the payer, you know, as long as we're connected to an EMR, we're extracting that data, helping the providers fill in the deficiencies or gaps in care, and taking that information and pushing it right back out to the payer so that a lot of manual labor is taken off of the staff at the provider level. Another great resource that we're now providing to all of our PCPs through our Collaborate platform is taking that patient claims data, mining it very deeply so that we can start comparing specialty care physicians and give primary care physicians another tool to make very intelligent, actionable decisions when they're sending their patient to a specialist and working with the most effective, efficient, highest quality provider possible. So it's objective data and taking the guesswork out of it so that, once again, the primary care physician can strive for that excellence in medicine by making a very timely decision. And campaign manager is another feature where we can reach out and run campaigns right from the platform, engaging physicians and or patients. And lastly, we have provided physicians with the expertise of preferred partners that align with Prime and function by conditions of participation that we outline at an ACO level on working with physicians and the providers, and bringing another level of expert subject matter expert resources and education to the physicians so that they really understand that they're not alone in managing the patient. They have resources that they can expand out to, kind of like a multi-D or multidisciplinary effort in managing patient care. And we do that sourcing and vetting of those resources and services for the physician and bring just those that really have some skin in the game and want to work just as hard, if not harder, for Prime ACO and supporting those physicians. So that's really Prime in a nutshell. We are physician-owned and operated, really focusing on the independent provider, trying to help the physician stay independent, aligning with an ACO. And as we're expanding in Michigan, Prime is also greatly expanding into the neighboring states and into as well as across the country. CMS, seeing that we have done a very good job promoting and sustaining and increasing that independent physician-owned and operated ACO model. We actually have physicians in Illinois, New York, Arizona, Nevada that have aligned with Prime, and we're further expanding into other states. And we're very proud of our accomplishments and being able to focus in on the mission vision of what CMS truly wanted in creating physician-owned and operated ACOs. So we welcome the opportunity to continue to expand CMS's mission and vision for what an ACO wants to be. So with that, I just want to end my presentation and field any questions or concerns that participants may have at this time.
Thank you, Diane. We do have quite a few questions. Let me start with the first one that came in quite early, and is that there a behavioral health component in the Prime accountable care?
We do have a behavioral health component. We're actually expanding upon that. And what we'd like to do is we're actually working and we're sourcing and vetting some opportunities now because we want to strengthen that. So one of the things we do have is one of the conditions of participation with a group that we're working with is looking at that socioeconomic factors as well as behavioral health issues and building something a little bit stronger into the ACO. So that is something that we're actually aggressively looking at now, building and enhancing upon what we already have.
And with that said, are you actively recruiting behavioral health providers at this point?
We are sourcing and vetting them, and we work with them in a manner that'll be more like a condition of participation, some kind of a contractual working relationship with that provider or resource, so that we still keep with CMS's vision of having primary care driven owned and operated ACOs while being very selective with the specialists with whom we work with. So we are aggressively sourcing and vetting providers as well as resources within the behavior health arena.
Good. Since we're on specialists, let me ask another question regarding specialists. A lot of the ACOs are geared very strongly towards primary care without necessarily including a lot of specialists. What is Prime's role with specialists?
So
in terms of them having their metrics.
Correct. Yeah. So right now, when Prime originally started, it was founded back in 2015, and there were some select specialists that wanted to align with an ACO. And so they did come into the ACO model. So when we received our first contract, January 1, 2016, there are a small handful of specialists that are directly related and linked to Prime. And what we're finding out is that because of how an ACO is structured, really from how the CMS model comes down in play, it's better to work with a specialist that's not necessarily aligned or that doesn't come under the ACO MSSP model, but we work with them, yes, select specialists within each area that Prime PCPs are actually functioning, so that we can have we can have a structure where everyone has, yes, some risk in the game, but also has the opportunity for tremendous resources as well as wonderful, lucrative financial outcomes. So how CMS structures their program today, looking at beneficiaries, beneficiary count, beneficiary data, those beneficiaries are really linked to the PCP. And so we're restructuring some things on our end so we can include the specialists, make it very engaging and rewarding for them, not just excellence in medicine from that clinical quality, but also from that financial aspect as well. So the board is very dedicated on including specialists. We're really taking a very conscious look at how we do that and wanting to work with specialists wherever our PCPs are located and really engaging them, yes, as our partner. So we're really strengthening that, and so that's what we're doing today.
Great. The next question is, what is your enrollment deadline for 2019 as well as for 2020?
Yeah, so an ACO must follow the CMS guidelines on when we can add physicians to the ACO. So we are talking with physicians currently, and CMS opens a very narrow window every single year to bring new physicians into an ACO. So at this moment, we are meeting with physicians. A physician does have to review and sign something called a participant agreement, and that wording comes, 99% of the wording comes right from CMS, and that 1% CMS requires an ACO to pepper in some of their information, which is, you know, our name, if we do have a protocol that we design at the ACO level, please be engaged with that. But that narrow window that CMS affords an ACO every year is, we're recruiting now, and I have until right around the early part of September in which to submit a signed participant agreement to have CMS consider and do their own vetting of that position for inclusion in a start of a January 1, 2020 start date with an ACO. So we're talking and meeting with physicians now, and we'll need something back from a physician as far as a next step, really towards the end of August, so that we can prep it for CMS timelines and when they want things returned for that September timeframe.
So, Diane, if providers are interested in reaching out to Prime, are you the best person to contact?
Yes, yeah. In the last presentation slide, so last slide in this presentation actually has my name, my email, and my phone number, and I am the best person to reach out to. I do all of the meeting with physicians, you know, when they're looking to come to Prime, and then I get the board involved, just so that a physician completely understands what an ACO is about, what CMS is looking for to go through that participant agreement, and then initially gather those materials that will eventually be submitted to CMS for CMS consideration.
Wonderful. The next question is, you mentioned ownership for the physicians. What is the onboarding fee and the annual fees?
Yeah, so Prime is pretty unique. And again, I can't underscore this enough. Prime was created by providers for providers. And so as we stand today, for a primary care physician to have some ownership in Prime, it really only is a $200 fee for a primary care physician. And that's a one-time fee to align with Prime. And the reason why the fee is so low is because physicians, especially at the primary care level, really understand that taking, 5-digit or 6-digit, membership fee to come into an ACO or any kind of organization it could be a real hardship on a primary care physician. And so Prime really thought long and hard as far as how do we meet a CMS mission vision of creating physician-owned and operated ACOs without breaking someone's wallet, but having some kind of skin in the game. So writing at least even like a $200 check for a primary care physician. And yes, signing an operating agreement so you understand how the ACO functions as a business really does put different things into perspective. So, this is an engagement with physicians so that don't think that you're signing on with an ACO and that someone's going to hand you a big giant check without changing what we're doing. CMS created ACOs with the intent of redesigning healthcare. So we really want to work with physicians, and that means, we have to change the way we're delivering healthcare today. Doesn't mean adding to anyone's plate, but just changing the way you're doing things. So with that said, it's a low ownership fee. It's collected at the time that a physician is vetted and approved by CMS, and it's that $200 one-time fee that we collect from a physician, and they sign an operating agreement to not just be a participant with Prime Accountable Care for a CMS MSSP contract, but to actually have ownership in Prime ACO.
Great. You had mentioned that there is a physician report card for the providers. Can you give some examples of the metrics that are on those?
Right. Yeah. And we it's a fluid document that enhances as CMS enhances its program. But we really focus it on 5 main key areas that we want physicians to really focus on and give them some kind of feedback so that everyone can keep in perspective how they're really functioning. So we look at EMR, quality metrics, engagement with Prime, engagement with the preferred partners or better resources that are out there that are of high quality, low cost, and then also their grasp and engagement of true population health management. So within each one of those 5 categories, we have anywhere from 4 to 5 areas that we engage physicians in, and we give them that feedback. And something as easy as like physician, EMR is physician maintains an active CMS approved accredited EMR. Shockingly enough, there are still physicians that may not use an EMR, or they do, and it's not at the highest level of version that it can be, so you can't maximize its full use, or it is an EMR and it's not accredited. So we just want to make sure that we're partnering with someone who has the tools and resources at the practice level that meets what CMS is looking for. You know, so another component within that EMR category is that everyone at the practice level, from the front desk person to the MA to the physician, the biller, if you have that person there, office manager, you're using the EMR to list capabilities, and that you have practice level protocols on how to document, code, and really save information to that EMR. Because if we go to extract data electronically from the EMR, and there's no real process at the practice level on saving information or how you're documenting things, we might go to the well, but we're not going to get any water out of it. So it's just making sure that we're talking with physicians and they understand that, hey, if you got an EMR, we expect you to use it in a very thoughtful, logical, intelligent way. And then, you know, allowing Prime or the Collaborate team, or IT analysts, access to that EMR, and not just once a year to extract data for reporting purposes, but on a monthly basis so that we can extract data for quality metric purposes, even predictive analytics, measure what kind of data is coming out of that so we can identify red flags, maybe coding issues, or things where things are not put in the right spot in an EMR, so that we can identify issues early on, so that we can work with practices throughout the year, so that we can improve and enhance and strengthen their ability at a practice level, so that now they become a very strong link in the ACO. So that's just kind of like a little example of what our practice, our physician provider, a report card looks like. This is not intended to ever be punitive. This is an open, objective measure of what we need to do across all fashions to be successful, and how people are measuring up, so that everyone can take the proper actions to be stronger at what they need to do, so that we can have a very strong ACO. And the reason why we put this together, again, it's not punitive, it's just timely, transparent, objective feedback, so that Prime does remain very strong as an ACO, as an independent, physician-owned and operated ACO. Because if physicians, which we know, they really should belong to an ACO. That's how MACRA is structured, that's how CMS is structured, that's how other payers are really being structured. Align with a very strong organization to provide that support, resources, training, and expertise, so that providers can be extremely successful. And, you know, at least in the state of Michigan, you have very few choices. You have 27 ACOs to join, very, very, very few choices for physician-owned and operated ACO. So if you want to be gobbled up by a large corporation, you know, that option's here. If you want to be gobbled up by a large hospital system, that option's there. But if you want to remain independent and really follow along CMS's mission vision, we offer that opportunity, but we'll only survive as strong as our, you know, weakest link is, if you will. So that's why we put that together.
I do want to ask one clarifying question. You indicated that you, through Collaborate, do collect monthly data, but is your dashboard for the providers real-time, or is it a monthly update?
So it depends on what you're looking for. So again, payer information only comes in on a monthly basis. So when a physician, let's say, launches Collaborate, and they look at the KPIs, the key performance indicators that we want physicians to be very aware of, that kind of an update really coming from a payer is only going to be updated monthly. But from a perspective of, and it's reflected appropriately within the dashboard. But now if another person within the practice, let's say maybe a care manager or one of the nurses, someone who has more clinical, additional clinical responsibilities, is looking for that ADT data, that's updated daily, real time. So depending on what the practice needs to do, the platform offers that information to them at their fingertip. So the dashboard is created to have those key performance indicators right up front so physicians can make timely, intelligent, actionable decisions, but also provides additional information on a real-time basis for other key stakeholders within the practice to clinically and financially manage care, and then work with those resources outside of the practice as a multi-D or multidisciplinary care coordination effort to work with the patient.
We do have a couple technology-related questions, Diane. Number one, do you pay for an EMR interface?
So what we're doing right now is the IT analysts that we work with Collaborate, we actually, the group that we work with that manages this large, robust population health management product, they actually work with over 30 ACOs across the country. So their IT analysts have the ability and expertise to work with a variety of EMRs. So they've pretty much seen everything. So within Prime, we have probably about 20 plus different EMRs, and where the IT analysts are able to work with the EMRs to gain access to it, as long as the physician understands based on where their version is, here's what we're able to do, and to get access to it. So we don't necessarily need to pay any kind of fee to the EMR. EMR company, we've not done that so far, but we're able to gain access based on proven processes, I guess, to gain that access, electronically extract that data, and work with the practice. So I guess, today we've not had to pay for anything. It's being done extremely successful at the Prime level. The IT analysts we work with are very successful doing this across the country with other ACOs and actually other physician organizations, because they also manage, it's payer agnostic, so we can have data from other payers coming into the platform as well. But we haven't had the need to expend dollars to have access to a physician's EMR.
Great. I am going to sneak in one last question here, Diane, before we end up having to stop, because we do have a lot more to go. Unfortunately, we are going to have to answer them via email. But the last question is, what are the savings and any possible financial incentives for the participants?
Okay, so if I understand the question correctly, you're talking about shared savings award that's received by the ACO from CMS?
I would interpret it that way, yes.
All right. So what Prime has done, we have looked at how to distribute that shared savings. So again, how an ACO works. You work that whole calendar year, let's say for let me give you the example, 2017. We worked all of 2017. 2018, CMS goes through its claims run out, its analyzing of the data, and then finally reporting whether an ACO receives shared savings in the fall of 18. So you're waiting a whole year and 3 quarters before an ACO understands what they received that shared savings. Upon receipt of those shared savings, Prime designed a methodology of how to distribute that. And so we look purely on objective CMS data. So we have it in 3 pools. So the first pool is basically an ownership. If you're a Prime owner and you own that ownership, we take those dollars being distributed to physicians, we put it today into 3 equal buckets. And the first bucket is paid out to a physician on ownership. Second bucket is paid out purely on the number of beneficiary count. So 100 beneficiaries times however many dollars in that pool, then that is a second check that's paid out to a physician. The third pool is based on cost and quality. And because we understand the patient claims cost, which again comes right from CMS for that particular program year, we understand the number of beneficiaries and who those beneficiaries are aligned to that TIN. We're able to, at a TIN level, practice level, understand the cost, create a benchmark, understand if you were below benchmark, at benchmark, or above benchmark, and what your quality score was based on the quality metrics, all at a TIN level. So it's all objective data based purely on the primary care actions, and we're able to view that to a physician down to the penny level, and physicians then are paid on pool 1, pool 2, and possibly pool 3 based on their cost and quality of their own patient claims data.
Awesome. That's great.
Well, that will conclude our presentation for today. Please remember that a link in recording and any additional reference documents will be emailed out to you from the email address that were provided for the Prime Accountable Care LLC. If you have any additional questions or comments, please do email the listed email address above.